you so much for waking up early. Um, I personally have missed being able to host students and learners from UCLA during the pandemic. So getting a chance to interact with you guys online is a close second, but I'm grateful for the opportunity to be here. I'm Chris Buck. I'm a pediatrician, and I've been working with UCLA for over 5 years now, leading the Mozambique partnership and doing clinical work in the Central Hospital Maputo and doing public health work with the government. And I started my career here with CDC, and I want to introduce Maria Ines, who's my colleague and collaborator and friend who's at CDC now. She works with me on a lot of the pediatric technical working groups for HIV and tuberculosis at the Ministry of Health. So, Ines, maybe you can turn on your camera and say hello to everybody.
Hello, everybody. Good afternoon and good morning for you on the other side of the world. My name is Maria Ines de Deus. I am a medical doctor working at CDC Mozambique for almost 5 years now as pediatric treatment specialist under the maternal and child health branch. And as Chris mentioned, I work closely with the Ministry of Health in the different technical working groups to help develop guidelines, training materials, and also do monitoring of HIV programming implementation by CDC supported partners. Thank you. It's a pleasure to be here.
Thank you, Maria Ines. So guys, what we've designed today is we have a talk. We're going to talk about prevention of mother-to-child transmission of HIV. And we have a little bit of theory and kind of practical content. And then after each section, we have an interactive part where we want the students and Maria Ines principally to have a discussion about what you guys could think are social factors here in Mozambique that could be contributing to some of our challenges. And Maria Ines is the perfect person to be on this call with us. She's Mozambican, she's a physician, she's a female. If there's no one that I know here who has probably better insight into all this than her. So I'm really grateful to have her join us. So I'm gonna share my screen and you guys can confirm if you can see my presentation. Yeah, are we good?
Yes.
Great. So yeah, we want to talk about social determinants of health and specifically in how it relates to transmission of HIV from mothers to babies in Mozambique. So we have 3 learning objectives that we designed for you guys or identified for today. We want to review what are some of the key strategies and interventions that are being put in place in Mozambique to try to prevent mother-to-child transmission of HIV. Excuse me. We want to see how we're doing. You know, the UNAIDS and WHO and these other bodies have set a goal for the elimination of mother-to-child transmission of HIV. They call that PMTCT, and they're lofty goals. And unfortunately, we're pretty far away from achieving those, but we want to show you how we're doing. And then we'd like to discuss, and probably most importantly for today, what are some of the country-specific or regional-specific social factors that affect key aspects of this cascade of care and prevention. So we hope to be able to leave the session with those objectives accomplished. I want to start with just a little bit of epidemiologic background. And a lot of the graphs I'll be showing come from this UNAIDS resource. I'll share the slides afterwards. And if you want to look at the document, here's a hyperlink. But this pie chart here shows in 2019, for children that were newly diagnosed with HIV, where did they come from? And you can see, unfortunately, that we're in second position here. Mozambique is only behind Nigeria. Our population is much, much smaller, but we have a much higher prevalence. So even compared to a country like South Africa, which is much more populous, Mozambique is producing more HIV-infected children per year. And so we're really the right people to be on the call with you guys to talk about challenges in PMTCT, unfortunately. This graph here shows what UNAIDS estimates to be the 6-week and final transmission rates after breastfeeding. So the green bars are the estimate of babies who are born exposed to HIV who test positive by 6 weeks. And the red bars are the estimate of children who are positive at the end of breastfeeding. And so you can see here, Mozambique currently has an estimated MTCT rate of 14%. And the graph on the right shows estimates about the number of new infections per children in children per year. And as you can see, we have not made much progress. We've made slight reductions, but it's still a major challenge for us. So PMTCT is a process of events and interventions that occur across different periods in a woman and a newborn's life. And we're going to use this framework today to talk about PMTCT and these pillars that were developed by WHO and UNICEF in terms of different phases in the cascade of care for women and their babies. So to start, I want to talk about the first pillar, which is, and you often when we talk about PMTCT as medical doctors, we start with number 3, and we start thinking about the biomedical interventions that we do in terms of treatment and prophylaxis. But really, if you think about it, PMTCT starts with keeping young women who will soon become mothers HIV free. So what's going on with primary prevention of HIV in Mozambique? The first graph shows something that is an unfortunate reality, not just in Mozambique, but around the region, and that young women have much higher prevalence of HIV than do young men. Part of this is because they have biological risk factors. Their vaginal and cervical mucosa still has a lot of columnar epithelium, which is more risk-prone to HIV acquisition, but that doesn't explain it all. There's some social factors at play, and we want to explore those today. On the top right, you can see a graph that shows in a recent survey some of the behavioral trends and that contribute to HIV transmission. And so only about half of young men and young women reported using a condom the last time they had sex with a non-regular partner. And only about a third of respondents had any knowledge about HIV prevention when they were surveyed. And so as a result, and again, not unexpectedly, the rate of new infections per year in young women in Mozambique is not reducing the way we'd like. These are two really interesting studies. I'm not going to focus a lot on clinical medicine today, but these are two really interesting studies that were done in Mozambique probably about 5 or 6 years ago. And what they did is colleagues who are working in Gaza province, which is our province that has the highest HIV prevalence, started studying women who enrolled in antenatal care. And they enrolled women who tested negative at their first antenatal visit. And then they followed them throughout the period of breastfeeding through pregnancy and breastfeeding. And they tested these women every 3 months to try to get an estimate of how many of them newly acquire HIV per year. And the results were shocking. Approximately 3 to 4% of these women who were enrolled in the study have seroconversion per year. And that has really big implications on our efforts to try to reduce new pediatric infections. So I don't have time to go into these studies in more detail, but again, I put the hyperlinks down here to the articles on PubMed if you want to read those as a follow-up. So this is our first break for discussion. And what I want to do is I want you guys to think about and engage in a discussion with Maria and Ines, but what social factors might explain this higher risk for HIV transmission in young women that we see in Mozambique. And I'm going to stop screen share so that we can see each other and have a discussion here. So I think what would probably be the best thing we can do is maybe have one or two students, at least 2 students, either by raising your hand or just unmuting yourself, try to respond to that question, and then Maria and Ines can take it from there, okay?
I can start. I think a piece of it is likely the amount of disclosing between partners that happens. and the number of sexual partners that young men versus young women are having during that period.
Thank you.
Yeah, it sounds like there's like not like sufficient education, I think, about prevention. And so I guess I'm wondering like what type of sexual education these people get, like what is the main form of education, all of those factors.
Thank you, Vivian. You both mentioned very key points that are important social determinants to increase the rate of HIV transmission in young women in Mozambique, and particularly in low developing countries. The first one is the level of education. How is the system of education in Africa? And in many of our countries, and particularly in Mozambique, we know that young women have low access to education. And even if they access the educational system, although there is a curriculum that includes HIV in general, what is HIV, how we can prevent HIV, these contents that are transmitted at schools are not fully absorbed by the women when they go back to their communities, they are on their social environment. They also have pressure from their families and from their community to get married early, and they don't have the position to negotiate the use of preventive measures during their sexual relationships. So those are economic and educational factors that affect the HIV transmission among women. There are other factors that, like cultural factors, that the men are the ones who decide when to do something in a house or in a relationship. So the decisions to wear a condom relies mostly on the men. So in order to protect the girls, we need to not only educate the girls, but also the boys to be able to allow them to practice safe sex during their relationship. We also have another social factor that it's very important for young women, is that these young women normally have all the sexual partners that can provide more and for her families or for her children. So the ability to negotiate safe sex it's reduced by these young women that are in a not strong decision-making position. Okay.
Thanks, Maria Ines. Would you mind telling the students just briefly about the DREAMS program and what the PEPFAR is trying to do? First of all, maybe tell them what PEPFAR is. Everybody might not know, and then tell them about the DREAMS program.
Yeah, so the PEPFAR program, it's an initiative led by it's a presidential, United States president initiative to support implementation of HIV programs throughout the world. And here in Mozambique, PEPFAR highly fund, I think, the majority of the HIV program initiative. And within this support, we developed the DREAMS program that it's intended to keep young women, adolescent and young women free from HIV. So we tackled this first prong of PMTCT cascade, the keep women free from HIV, preventing HIV, primary prevention. So we work at schools and at community level, identifying DREAMS ambassador that are trained and educated to go out to the schools and to the community to train and educate other young women on the prevention activities and how to keep safe and how to do safe sex and avoid HIV transmission. It's in summary what we do with the DREAM program.
Awesome. Thank you, Maria Ines. And guys, if you're interested, there's good stuff on the internet about DREAMS and what it's doing in all the different priority countries. So I'm going to go back to sharing my screen and we're going to tackle the next pillar. I'm sorry, let me fix that here. Are we back? Can you guys see that?
Yep.
Okay, thanks. Okay, so pillar 2, let's talk about this. And so let's imagine that we failed pillar 1 and we have a young woman who's HIV positive. The next point where we have a chance to intervene to prevent new pediatric infections is to make sure that women who are HIV positive don't have unwanted pregnancies. So essentially implementing family planning services for this population of young women. And we have big challenges in this in Mozambique, particularly for the younger women. This is an analysis, a situational analysis or a landscape analysis that was done by a group here called Think Well. And again, I put the link down here if you want more information. The graph on the left shows for all patients, what percentage of health facilities have these available contraceptive methods. And so you can see Plan B is only available in about 50% of health facilities. But if you look at all forms of contraceptive methods, 94% of the facilities in the country offer some sort of service for women. The chart on the right shows specifically for adolescents and youth. So for younger women who are more frequently the population that that Maria Ines is focusing on with the DREAMS program, and you can see that the percentages tend to be a little bit lower, and only 2/3 of facilities in the country have specific family planning services or specific clinics set up to kind of cater to the needs, the unique needs and challenges of family planning in a younger population. I didn't find a good graph to show you guys to show you what the uptake of these services is. This is the availability, the theoretical availability of family planning at health facilities, but in practice, the uptake is much lower. And so I don't have good statistics with you to share with you today. It's not something I focus on a lot in my work, but we know that not everyone that even probably who wants to do family planning is actually doing it in Mozambique right now. So that's the only slide I have for this section. I'm going to stop again, and I want you guys to think about, and there might be some overlap with the last section, but what social factors might be at play here to explain the low uptake of family planning services, not just the availability, but the actually when it is available, what might prevent young women or women of childbearing age from actually using those services. So I'm going to stop my screen share again and turn it over to Maria Ines.
So who wants to come first?
I was wondering, do you have to be at certain age to access these resources, or if parental consent is needed, if it was a minor to access these?
Yes, definitely, Julia. This is a key factor that affects the ability of young adolescent and young women to access service, is the need of parental consent to get some type of service, from HIV testing and even to have access to some contraceptive methods that are more invasive. Currently, Mozambique has implemented the family planning services in all health facilities, but first, the access to the sites, it's difficult. Women doesn't have the required transportation to go to the funds to access transport to go to the sites. If they reach the sites, there are also limiting factors. One is if they are on younger age, they need consent from their caregivers to take the pills back home. We have young women that start sexual activity when they are 10, 12 years, and they need parental consent to do some, let's say, more invasive procedures. And that's also a limiting factor. Another limiting factor is even though in those health facilities, we have people there that provide the service, they are not well skilled or trained to provide the service specific for the adolescent and young women. There are not sufficient friendly spaces so that they can access and feel comfortable to go back. I don't want to go to a family planning clinic with my mother on my side. It's kind of awkward. So adolescent, teenagers, and young women doesn't go because there are lack of these friendly services. So those are some of the limiting factors to access the service that exists, besides the difficulties to access overall healthcare services in our country. And on the other hand, we